Okay, I'm going to show you how to put in a saline lock. We're going to put in a saline lock, hang some IV fluids, and then we're going to discontinue the IV today. So the first thing, we're going to be going by this checklist. We're going to do the skills performance checklist. First thing I want you to do is review the order. You need an order to put in, to put fluids. And fluids is just like any other medication, so you do need an order. So you would need to be checking that order. All right, so let's say they have an order for normal saline at 75 an hour. You need to make sure you get the right type of fluids at the right rate. Okay, so we would pull out, you know, our normal saline out of the Pyxis using our 3 checks, 11 rights, all that. We're also going to be checking the chart for various things that can affect site selection. Let's say they have a dialysis graft, or let's say that there is any disease processes. Let's say they have like a broken arm, or let's say they have a CVA. You wouldn't want to use that arm on that, you know, the one that's has paralysis. I also would be thinking about their age when I go to put in a line. Maybe if they're a really frail, thin, old person, I might not want to use their hand. Maybe I want to go up a little higher. Of course, with babies, you know, you have to think about where you're going to put that to. A lot of times we use their scalp and all that. I know that sounds weird, but we do. Mobility level. I wouldn't necessarily want to put it on the bend. I'm usually going to start lower and go in from the most distal, go up, because if I put the IV in here, and let's say I put it in here, I couldn't put it lower because once I pull it out, it could leak in the tissue. So I want to start lower and then go higher, making sure to not use the same vein distally that I'd used before. Okay, I would want to check their lab values, make sure that the ordered fluids are the correct type of fluids. So let's say I have an order for D5.5 with 20K and their potassium level is 5.6. What would I do about that? Of course, I would question that order because that is not the correct. Obviously, there's a problem there, right? So they have high potassium and you want me to give them potassium, so I'd question that order. So I'm going to look at all those labs, the sodium and the chloride. I may even want to check their H&H. If it's low, I would be considering, well, am I in the future going to have to give them blood? Maybe I would be wanting to use not a 22 gauge. Maybe I'd want a 20 gauge. That's about the smallest I would use for blood. So I'd use an 18 or 20. By the way, when we speak of gauge, it's kind of like what we did with needles before when we gave IM injections. It's opposite of what you think it is. So an 18 gauge is bigger, thicker than a 20. So 22 is smaller. Okay, so 20 is kind of in the middle. It's a good one. We typically use a lot for adults. All right, so allergies, making sure they're not allergic to tape, to any kind of latex, any of that kind of stuff. Or, of course, the fluids, if they're not allergic to it. Let's say I'm hanging Rocephin, you know, and they're allergic to it. So, you know, if I'm hanging some kind of antibiotic or something like that, making sure. All right, so then I want to gather my equipment, wash my hands. So what kind of equipment do you think I need? I'll probably need something to protect the bed, a towel or a Chuck's pad, something like that. I'm going to definitely want gloves. I need my fluids that I pulled out already. It was normal saline at 75, so I make sure I have my normal saline, and I need my tubing. It could be pump tubing, it could be just regular tubing. This is just going to be a regular tubing, and I'm going to hang this like you guys did in lab already. So this is going to be continuous flow tubing. The drops are up here in the corner, 10 drops per ml. So I'm going to make sure to note that, the 10 drops per ml, because that's going to come in handy when I actually hang that fluid. If I have to count the drops, I'm going to need to count those drops, and so I need to know what that drop factor is. So, but I'm going to, instead of hanging it directly, you can hang directly from the IV tubing and hang it directly into the line, which sometimes happens in the ER, or sometimes happens in the ambulance, or sometimes happens in the OR. But since I'm up on the floor, I'm probably going to go ahead and take the extra time to put in a saline lock first. You can see a saline lock that has an extension tubing that looks like this, or this, or you may see that the saline lock part of it is just this part. This goes into the IV like that. I'm putting an extension tubing on it so that this part will go into the arm, and this part is more free, which I'll tape down. The reason why I chose to put the extension tubing is that if I have to get into this lock a lot, like let's say I have to use this every 6 hours to give IV antibiotics, I may want to put the extension tubing so I'm not constantly up there moving this around. If if I just put it in, for sometimes we used to, when I worked in telemetry, we would just put the IV, saline lock in, and it was only used for emergency, and I didn't have to use it very often. I might just put just the saline lock in without the extension tubing. So based on the needs of the patient is to what I would use. Like I said, I'm going to use the extension tubing because that way I'm not constantly moving this part around that's in the arm. I'm moving around when I'm trying to flush, and I'm moving the very end around right here instead of this that's close inside the arm. I'm going to take that down real well. So I've got my saline lock with extension tubing. I'm going to get a saline flush. This of course would come in a package, it's brand new, you know, and this comes in a package too, and it's sterile. Okay, so I have this in a package, sterile, brand new. I'm going to get my IV, my catheter. I chose a 20 gauge, so that's what I'm going to bring into the room. You could bring 2. After 2 sticks, I say probably just not your day. Get somebody else to try and stick that person, because if you keep sticking and you keep blowing that vein and you just keep doing it, you're going to run out of spots. And there's only so many spots in the arm. So if you keep, after 2, I usually say, okay, I'm done. I'm letting somebody else do this. All right? Whether it's another nurse or, you know, on the floor, or whether I have to call IV therapy to come and get it up. I'm also going to bring in a tourniquet. I'm going to bring in some tape. I'm going to bring in a Tegaderm. It's a clear dressing to put on the site so that I can see it, okay, instead of like a 2x2 or something. I don't want it to be where I can't see the insertion site, so it's going to be a clear dressing. I need to bring in some kind of ChloraPrep to clean the site, and you can see them, they look different. Some looks like this, some looks like this. What you do is you open them though, so maybe this is what your hospital has, maybe this is what your hospital carries. I might bring in a calculator to help me count drops, like so the extension tubing. I would also bring in a little scrubby hub thing, so when I actually go to hook up my IV fluids, I'll scrub the hub before I actually, you know, hook it up. And I'm trying to think if there's anything else. I mean, of course, there's going to be a needle box in the room. All right, so I gather my equipment and I wash my hands. I come in, identify the patient, and explain what I'm going to do. I'm going to go ahead and put a little catheter into your, it's a little tiny catheter. I'm just going to put this into your vein, and this is how we're going to give you IV fluids. The needle, I'll put a needle, but the needle will come out and it will just, the little catheter will be left in. Okay, so I tell them what I'm going to do. I've identified them, name, date of birth, check their allergies, and explain the procedure. I'm going to prime the saline lock and prepare the equipment. So this would come out of a package brand new, okay? So as long as I haven't touched this, it's still sterile. I don't necessarily have to clean this hub, but if I did, I could clean it with a hub scrub if I touched it by accident. This is a hub scrub, and you put it on there and you clean it, clean it, clean it, clean it. If your facility doesn't have that, you would just use alcohol swab very well. I've got my brand new saline, all right, and this comes with this unclamped. I got my brand new saline. I would take off the cap off of that. And of course, you guys know that if you don't have these salines pre-filled, you guys know how to get out of a vial, how to get saline into a syringe. You guys learned that in fundamentals. So once I get this, I connect this to the saline lock, push it, put it in, twist it, and then I just loosen this up just a tiny bit so that when I prime it, I want to make sure my saline, and it's not going to do anything until I push, that my saline goes all the way to the very end. I want this to be filled with saline because I don't want to hook it up and then not have any saline in there. If I do that, I would actually get air into my vessels. We don't want air in our vessels. So this needs to be primed all the way. So I prime it until I see little drips of saline come out. And then I just keep the lid on, so you want to keep it clean and sterile. And then just set it on the table. I'm going to go ahead and keep this saline lock attached. All right. Now I'm going to go ahead and prepare everything that I need prepared. I'm going to take my Tegaderm out of the package. Make sure you read the Tegaderm to see how it is that you put this dressing on. There's a dressing like this. The back will come off, and then we'll take the green off and then the blue off. That's how, but it tells you on the back step by step how this dressing works. So they all work slightly different. So I'm going to have that. I'm going to have my dressing. I'm going to put this over here for a second. I'm going to use that last. Of course, this arm would not be stuck on the table. I'm going to go ahead and put my towel underneath my arm. And I'm going to try and find a most distal vein. Now I have a general idea of where I'm going to look, but I don't really know for certain until I put the tourniquet on. Because it's really not just about what they look like, it's about how they feel. Do they feel like they have juicy blood in them, really? Is it straight? Is it long enough? Will I be able to get it in? This is, if you look at this is a 1 1/4 inch. So I have to have at least a vein long enough and straight enough to get that catheter in without it, so it doesn't twist and turn and bend and all that. And I'm going to try and go most distal unless I can't. Let's say it's a really old person and they have really fragile veins and I can't use their hand. But I'm going to try. That's going to be my attempt. So let me go ahead and get everything else ready real quick. So I've got my dressing, I've got my saline lock primed, I've got my betadine, sorry, not my hexachlorine to clean, my ChloraPrep. I've got my IV. I'm going to go ahead and tear tape. Now make sure your table's clean. Now there's some controversy of whether you can put tape on the table. We're going to be putting the dressing, the clear part of the dressing down first, so it's going to be close to the skin. So if you're doing that, which you shouldn't be putting the tape next to the skin, then usually that's not an issue because your tape is on top, but still your table needs to be clean. If you work at a facility that you can't, you just open it up and you put it inside your container. Inside, you can use your tape on the inside of this. Okay, but I'm going to put it on the edge of the table because I'm going to be putting this tape on top of the dressing, not underneath the dressing. So I tear it in half, about this long, and then tore it in half, okay? And then maybe another piece. Okay. All right, so I'm going to, before I actually put my gloves on, you can do it with your gloves on or without your gloves on. It really doesn't matter to me, truthfully. Maybe I'll go ahead and put my gloves on first, just to find my vessel. Some people say they can't feel the vessel with their gloves on, and that's okay. If that's the case, then you just put your gloves on after. But I can feel just fine with my gloves on. So I'm going to go a little bit above where I think I'm going to go, but like I said, I don't know for certain until I get this tourniquet on. So I take the tourniquet, I hold it in one hand, I pull with the other, and then I tuck it under. I want to be able to loosen it when I need it. Okay. I'm going to look at this and I'm going to select my site, looking at the length of the site, if that vein is straight, does it feel like it's got good blood supply? When I push down, does it kind of push back at me? You can feel it. And I'm looking to see, it looks like it's good. So now I'm going to clean it. Once I clean it, I can't touch it. So make sure you've got the area selected before you start to clean. So I squeeze open my chlorhexaprep. And with chlorhexaprep, it's a scrubbing motion that kills. You know, like you normally do a dressing, it starts from the center and then goes the outside when you're doing any kind of wound care. Well, it's a little different. Like if you did alcohol, you would start from the center and go out like when we do our IM injections. But with chlorhexaprep, it's about scrub, 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 scrub. So we do this and we hold and we clean that area really well by scrubbing it with this liquid ChloraPrep. Scrub, 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 scrub. One way, scrub, 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 scrub the other way. And then let it dry. This would be tossed. All right, so I've decided that it looks good. I can't touch it anymore. I want to get my needle and take the cap off. Okay. Now some people say these stick a little bit. If you're worried about that, what you do is you just loosen it up a little bit, but please don't loosen it all the way up and then try to rethread it. That is what causes problems with the catheter breaking. Do not do that. I don't know if you can see this really well, but the needle is in the inside. The catheter is over the needle, so it's an over the needle catheter. So this part stays, and don't touch it but on a real person, but this part is what stays inside the patient where the needle comes out. Okay, so like I said, some people just loosen it up a little bit and then push it right back down, but please don't thread it all the way off and then try and rethread it. That is a big no-no. Okay, so this I've never touched it, pretend, okay? So this is my catheter. This little hub part right here, this is going to be up, all right? If you can see the bevel of the needle, that part is going to be up as well. So I'm going to stabilize pull my arm down, stabilize my vessel, stabilize my vein. The hub is up, and I'm going to insert at an angle about 15 degrees, 10, 15. You don't want to go so much that you go through. If you're going like this, you're going to take and go right, here's my vein, you're going to go right through the vein. But you don't want to be like just parallel, because you're just going to skim the vein. You want to actually get it in there. So here's my vein, I'm going in there, like boom. And when I see it, then I'll drop it down a little bit. But I don't want to push all the way through. I don't want to be 45. I'm talking about 15, boom, I'm in. Okay, so I'm going in, needle bevel up. Keep your thumb off of this. You want that to be sterile. You don't want to be touching all over this stuff. This is sterile. This is an aseptic procedure. So go in, boom, I see blood. Flashback is coming all up inside this pink. Okay, when I see that, I kind of lower it down, advance a little bit. Then I'm holding on to the clear part. While I take this, I let go of this, and then I'm going to take and thread the pink all the way up and to the skin. So thread this all the way up. Now, so far so good? Okay. Before I go and do anything else, I've got blood starting to flow into this. I'm going to pop the tourniquet off, because I don't need this to be a big juicy vein anymore. It's in there. Blood is coming everywhere if I don't do something. So I'm going to pop this off, and then I'm going to put some pressure above where the catheter is. So that catheter is about this long. I'm going to put pressure above on that vessel. I don't want to put it too close, because I don't want to push the needle up through my vessel. So I'm going to put pressure above where that needle catheter will come out. And then I'm going to stabilize this catheter with my finger and put it on the pink part. I don't want my fingers all over it though, but just stabilize it. Pull the needle out. And I'm just going to put it on the table, but remember that I have to throw that away. Now I've got a cap on the end of this. I'm not really good about flicking it off with one finger. Some people just flick it off with one finger. I'm not so good at that. So I come over here and I put it in here, take it off without touching any of the part that needs to be sterile. I'm going to hook this up. I'm holding pressure here. It's preventing the blood from flowing out and making a big mess. I put it on. Once I got that on, I can help to tighten it like this. Now, so I push it in and I screw it to the right, turn to the right. Righty-tighty, lefty-loosey. Now it's on. Now I'm going to flush it to make sure it's flowing. Does it look like when I'm flushing that it doesn't have a big, mess there? When I flushed it, did it look like it was infiltrated? I don't want to see any saline going underneath the tissue in the skin, any big bumps. And then once I flush that, I can go ahead and take that off. Now I've got the catheter on. This is on right here like this, and it's in. So what can I do now? I need to put the dressing on. So I have this dressing. I'm going to take the back of it off. You notice I'm still kind of holding on, because if they don't move, they move their arm right now, and I just have it flopping, it could actually fall off. Fall out, and I don't want to, that hurts, to put it in. So I'm going to take the back of this dressing off, and if I hold on to it, see how it stays stiff on me? Keep your fingers off the inside of that, because it's going to be, then I'm going to cover it about like this. I'll show you, I'll bring this over here. I'm going to cover all the pink part of it. So it looks like this right now. All right, so I've covered it up to about here where the pink is. I didn't necessarily put it on the connection, but you can. That's not as big of a deal. Okay, so I covered it there. And then I'm going to take the green off, smooth it. Then I take the blue part off. And smooth it. Now I have the dressing on, and some people will say, well, that's okay, right, like this. I'm going to have you secure it a little bit more. If your facility says no, you don't need to put any more tape on it, that's fine. Some people will just put tape right on top, boom, and that's it. And some facilities do that, and that's fine. But some facilities will also do where they put a, they secure it a little bit more with, like, they stick a V underneath like this, so you put the tape underneath it. Now, if you do this, you do not go shoving it and disrupting that dressing. This is just to keep the catheter a little more stable. I do not try and shove this tape way under there. This dressing is secure. Do not unsecure that dressing. So I put this about right here, sticky side up, and I'm going to make a chevron. So the sticky side is up, it's laying underneath there without disturbing this clear tegaderm dressing. I make a chevron by turning it on top of itself like this, and then I turn the other one on top of itself like this, and then I take the other piece of tape and I put that on top like that, and it makes a chevron. It makes it very secure. Now it's still not secure enough for me. I still don't like this flopping around. So I'm going to take the other piece of tape and make a loop. When you make a loop, you want to make sure that your loop is in an area that it's not going to cause problems. You don't want it to be so loopy, though, that you cause a kink in the tubing, because then it won't flow correctly. Now, when I make the tape, I don't put the tape on top of where the insertion side is. I need to be able to see that very well. And I've got a nice piece of clear tape on, or clear tegaderm. I don't want to cover that clear tegaderm with tape, even though this tape is clear. Still, I want to see it as best as I can. So I'm going to put this tape over here and secure this. Okay. Now I need to date, time, initial, engage, and put that, write that on either a piece of tape or a sticker. Sometimes they have little stickers that you can stick on and label that. Okay? Okay. So we have done step 1, step 2, step 3, step 4. We have applied glove and prepared catheter, performed the venipuncture, flash bag, advanced the catheter, released the tourniquet, stabilized the catheter, applied pressure to the end, retracted the needle. We've connected the IV and saline to flush the line, assessed for patient, and then we applied the dressing, we secured the tape, we labeled it. Now we need to appropriately discard everything. So get this needle and throw it into the needle box. By the way, you notice how I'm throwing it in the needle box, I'm dropping it, I'm not shoving my fingers in there and closing it. All right, so that's, and I clean that. Now I still need to go ahead and just hang my IV fluids. All right. So wash my hands so I can hang my IV fluids now. This is just like you guys did before. So I check my fluids, you know, I've done my 3 checks on my 11 rights, and I'm going to go ahead and open up my bag of fluids. Usually there's a little notch where you can tear. Don't take a scissors to this, you can cut the bag. So open this up. Once I got my fluids opened, I'm going to look to make sure the fluids are clear, there's no sediment in there, there's nothing that looks wrong with it, it's not leaking, it's all intact. Then I'm going to open my tubing up. These rip open also. This was 10 drop tubing. You may have 10 drop or 15 drop, which is macro, or you could have 60 drop that's got the little tiny drops, which are 60 drops in an ml tubing. This is just 10 drops. So I've got my tubing. Whenever you open any kind of tubing, I don't know if you remember from last semester, I talked about NG, like the tube, the bags. Anything that comes is usually going to be, the roller clamp is going to be open, and they do that to prevent it from causing damage to it. So I'm going to take the roller clamp and I'm going to adjust it to however I want it, and then I'm going to, first thing first is I'm going to shut the roller clamp. Please do that, because you will forget and you'll have a big mess everywhere. So close the roller clamp as such. The roller clamp goes down, you can tell it's closed because it won't move. So then I've got my fluids, and I'm going to look and see which side needs to be pulled off. Sometimes it looks different, it's hard to tell, but it's the one that does not look like you can stick a needle in it, because the pharmacy, they use this to clean the pore and stick needle in it with solution, so they may add antibiotics to saline or whatever, to defy, whatever. So you take off the other one. So when you take it off, make sure that you're not contaminating it. So when you take it off, your fingers shouldn't be all over here, should be licking it or anything. So take it off straight. Gotta have some strength there, straight, and pull it off. Keep your fingers away from it. Now, I notice I don't have gloves on. I don't need gloves, sterile gloves on or anything. They would just get contaminated right away, right? But I need to keep this aseptic. This needs to be sterile procedure. So this needs to be sterile here. And when I take this cap off, this needs to be sterile. If I go and touch this with my fingers, it's no longer sterile. So keep your fingers off of that. Now I need to connect this to this. So this here, I'm going to spike the tubing by pushing it in. Sometimes you have to push a little harder than you think. And be careful that you're not bending like this. I can tell you I've done that before, and it's not a pretty sight where you stick it in. I just admit this, I did it to blood and I ruined a whole thing of blood. I was in such a hurry, I had it bent, and I poked right through it. So if I can give you any warning, keep it straight while you're twisting and turning and pushing so that it goes up to where it needs to go. Now you want to put it up all the way, because if you don't, anything that's exposed, it will have germs on it. So then the next time when you go and switch the bag out, you don't want to have germs being put in. So you're going to put it in as far as it can go without keeping it straight so that you don't poke through this. If you poke through this in any way, it becomes contaminated. It's not good anymore. So, by the way, not good anymore if you have this and it's dropping all over the floor. If it touches the floor, it's not good. Okay? So, I'm going to hang it. By the way, you could have also hung it on the bag, pulled the thing, and pushed it in this way. Because even if you take the little cap off it, until you spike it through, it's not open. So I could have hung it and then poked up this way. So now I got it here. I want to fill the chamber about halfway full. And just like I said, I need to prime my saline lock. I need to prime my tubing. If my tubing is not primed, I will be putting air into that person's body. Air will go into the vein. I can have an air emboli, and that is not something I want. And now, to my knowledge, I don't know if there's any studies to how much air would cause an air emboli. That would not be a study that would be approved, right? Because that could really hurt somebody. So then once I've got it primed, this chamber filled halfway, then I'm going to loosen this up a little bit. Again, I never take it completely off. Some people do, and that's okay, but just make sure if you take it completely off that you don't contaminate it. Just like I did over here, I keep it above waist, and then I just hold it and fill it until the fluid comes out. So that all the very end, getting all those little air bubbles out. It helps sometimes if you're going to the air bubbles if you tilt this down while it goes through these little areas so that the air comes out of this little area too. All right, so once it's all primed, it's ready to go, turn it off. Now I need to hook this up to, I'm going to hook it directly to, I'm going to hook this directly to my saline lock extension tubing. This here is the lock part. This was the extension tubing that went into the patient. So here's the lock. It's already been flushed, it's already been primed, but I've been touching it, touch, making it dirty and germy. So I need to open one of these containers. These are the little things that you clean it with, okay? So I'm going to scrub the hub. So take this in here and scrub it. No, usually it's like 20-30 seconds. Scrub that hub. Make sure it's good. Because I don't know if you notice these. There are little grooves all in here, and they can get germy and really gets disgusting. So if you're not if you don't scrub this really well, you're introducing germs directly into that person's vessels, into their veins, into their blood supply, which goes to the heart, right? So we don't want that. So I've scrubbed my hub on my saline lock. Scrub, scrub, scrub. Scrub, 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 scrub. Then I can take, again, be careful not to contaminate. Take this off. Do not touch here. If you do, it's contaminated. After I'm scrubbed, I hook it up, push it, twist it, righty-tighty, lefty-loosey. So tighten it up. There's a little knob that tightens. And then I could put a piece of tape on here. And then I would set my drops. So what could I set my drops at? The drops say it was 75 mils per hour. 75 mils per hour. So if I have 75 mils per hour and I have 10 drops per ml, I can do, and I can show you the math if you guys need, 75 times 10 equals, divided by, there's 60 drops in a minute. 60 seconds in a minute by 60 is 75 times 10 equals divided by 60. 12.5. 12.5 drops per minute. Now I come over here. This is how you adjust up and down, makes it flow. And I don't want to have it flow to my arm, so I'm just going to show you what happens. So I would sit here, I need to have 12.5, which is kind of hard to do 12.5, so about 12 drops per minute, right? I could put it on a pump and do that accurately, or I can count it. Now, it's hard for me to sit and count something over a whole minute, but it's pretty easy for me to count something over 15 seconds. So let's say I need 12 divided to get 60 seconds divided by 4 is 15 seconds. So 12 divided by 4 is 3. So I need 3 drops for every 15 seconds. So I would count 3, watch it drop 3 times in the 15 seconds. Now I know that I need like around 12 drops per minute. So then after I get the 3 per 15 seconds, I go back over that minute and get the 12 drops per minute. And of course, if you do gravity, you have to have, usually you have to have a little tick mark thing. You have a little time thing where it says, okay, it should be at this time, this at this time, this at this time, this at this time, this at this time. It gives its little, we time it with a little piece of tab that will tell the times it's at. And most of the time we use pumps, but you still should know how to count drops in case there's no pump available. ER, OR, you might not have it right away. If you're on an ambulance, you might not, obviously. If the power goes down and you're, I don't know, Hurricane Katrina, you probably are going to be using things like this, where you're just counting drops. So you do still need to know how to count drops. It's not something that we're just completely saying, oh, we always have pumps. So now the pumps, I'll show you in class how we can, how the pumps work. All pumps are different, but you just program the numbers in. All right, so that is going to be your checkout. So this would be hooked up to the patient by the time it's done. Now, part of your checkout is you're going to have to discontinue. So this would be hooked up. Okay. So part of the checkout is after it's inserted, we would say, okay, well, what are you going to chart? So I would chart that I inserted a 20 gauge IV catheter, saline lock, into, where did I put it? Into their left hand. Actually, yeah, their left hand. How many attempts did it take? Times 1 attempt. Patient tolerated well. Then what I do, I hooked up saline at 75 mils per hour. All right, so then, like I said, part of your checkout is that you need to discontinue it. So what do you need to do to discontinue it? Well, you want to make sure to stop your IV fluids, as soon as you don't want those flowing. Well, if you have a saline lock, just lock the saline lock. You can get rid of these fluids. With a saline lock, you won't have the blood backing up. If you just did it for a regular IV, you might have fluid backing up if you held the IV lower or anything like that. With a saline lock, if you don't want any blood to back up, you've got this here is like a positive pressure, but also this here little clamp will clamp it so it helps to create a positive pressure so the blood doesn't back in it. Okay, so both kind of things help. This little saline lock itself helps to prevent that blood from backing up, so does this little clamp. So I've clamped it, and then I want to get everything prepared that I need to take that out. So what do I need? I'll probably need something underneath her arm in case things get bloody again. That's not as big of a deal. I definitely need my gloves. I know I had some here, but I want to go grab another pair. So I'm gonna pretend like I put my gloves on. Didn't bring them in this room. So anyway, I'm gonna put my gloves on. I'm gonna go ahead and I'm gonna open my 2x2. Guys, just like you learn in fundamentals, when you open packages, you open using a sterile technique. I know that this is not a sterile procedure taking this out, but whenever we want to use medical asepsis, we want to stay as clean as possible. We want to spread germs. And if I have my hands all over this, that's going to touch the site that I pull out. There's still a little opening in the skin that's going to touch that. I do not want my germs all going, possibly invading their skin, because that's a break in the skin. So I've got my gloves on, pretend, right? I come in, identify my patient, name, date of birth, allergies, all that, right? And I'm prepared for removal. Now, I'm going to take my Tegaderm off, my tapered Tegaderm off. If you have a hard time taking this Tegaderm off, if you put a little alcohol inside on it, it'll kind of loosen. But I take it and I kind of pull and it kind of loosens itself too. So if I kind of pull and it kind of loosens, then I pull it all together. Once I got it all kind of in a ball, I get my 2x2 and I kind of, you know, my wonton thing, I kind of get it so that this here was completely clean. I touch just the corners and I kind of pull. So let's say their hands up, I'm gonna pull and pull this out and put pressure on this. I usually hold some pressure on here. When I pull it out, it's important that I pull it out and look to see what the catheter looks like. That catheter needs to be intact. If there's a piece of it missing, that's a big deal, okay? So I'm looking to see if the catheter's intact. It is, and of course I want to throw this, I'm going to throw the whole thing in the needle box, okay? So just throw it in the needle box. And I'm holding pressure until it stops bleeding. Well, you know, people say, well, how many minutes is that? Well, you know, I can't really tell you that. It depends on why might I need to hold pressure longer on some patients. Well, maybe they've had, they're on blood thinner, maybe they've had heparin, maybe they're, who knows, maybe they're taking Coumadin, whatever. So sometimes you have to hold longer than other times. So I'm going to sit there and hold it until the pressure, I think the pressure stopped. And then I can take a little peek and see if it stopped. I can put a little Band-Aid on, or I can just put a little piece of tape on this right then and there. And that is how you take that out. Then you need to document it. So when I document, I'm going to say what I removed. I removed 20 gauge catheter from the left hand. Left hand catheter is intact. Catheter intact. That's important to note. And that's the IV checkout.